ladies and gentlemen, thank you so much for being here with us at Focus Point 360 APEC Roadshow. So right here, we are very excited to bring you something truly valuable because we are going to have this eye health talk by professionals. And today's topic, we are talking about the silent thief of sight, how most blinding conditions are silent. And today's sessions, we are honored to invite 3 speakers to be with me today. And today, these sessions will be sharing with you the importance of early eye screening and how many vision problem shows no symptom until it's too late. So today, we are very honored to invite 3 amazing speakers with us. We have Miss Cha Joyen, the Professional Service Manager, the Head of Training and Development of Focus Point. And we also have Dr. Tan Tai Keong, the Consultant of Ophthalmologist and Glaucoma Specialist in ISEC Mid-Valley. And we also do have Miss Dini Dayana, the Optometrist of Focus Point PJ Old Town. So they are here to help us understand why many eye diseases show no symptom until it's too late and how we can take early steps to protect our vision. Ladies and gentlemen, can I have a big round of applause to the speakers on stage? All right, so let's begin our session. Before that, can I have all of you to do a short introduction about yourself?
Hi everyone, my name is Chia. I'm from Focus Point HQ. So I'm the head of training and development. So I've been in the industry for more than 15 years. Currently, it's my 3rd year with Focus Point lah. Yeah. So.
Okay. Hello, my name is Dini. I'm graduated from a Bachelor of Optometry from UiTM University Technology Mara. So I've been working with Focus Point currently, and since I joining Focus Point, I joined in more than 9 roadshow already lah. So I'm enjoying to do roadshow very much because I can communicate with you guys. So so far, that's all for me.
Hi everyone, my name is Dr. Tan. I'm from ISEC Mid-Valley KL. I'm a consultant ophthalmologist and glaucoma specialist in ISEC Mid-Valley KL.
Thank you so much to have 3 speakers today onwards with us. So first of all, we'd like the questions to Dini, Miss Dini. So could you share a little bit of quick overview of the eye structure and also how the vision system works?
Okay, so as we know, since primary school, we already know what is eye, right? So I want to go details about eye, but make you more understand lah about what is eye is. Okay, I will highlight a few points of the eye structure. The first one, I will tell about 6 layers of the eye. The first layer of the eye is a cornea lah. After that, we have a iris and also pupil. So pupil is I oftenly ask the patient or customer over here because you know what is pupil is a small black hole inside of the eye. Some people misunderstood the iris. Iris is colored part of the eye lah. Okay, some people got black color, some people got brown color, blue, green, depends lah. And then we got a lens. Lens is transparent color. This is the middle of the eye where cataract start. Okay, and then we got a retina. Retina is the layer at the back layer of the eye. It's like a screen lah. Okay, like because eye is commonly compared with camera. So camera is a screen at the camera lah, okay. And then the last part of the eye is an optic nerve. So every part of our eye, every part of our body got nerve, as including our eye lah. Okay. So I want to also explain to you how actually our eye work is by when we see something, the light is passed through our cornea part first. Okay. The cornea part is like a window lah. Front window of our eye, and then it will pass through the pupil. It's well controlled by the iris. So iris muscle will dilate or constrict at the pupil size to control the amount of the light when it's coming to our lens. So the lens will focusing perfectly how the vision should be. Okay, if you've got a longer eyeball, maybe it will with a spectacle it will focus on the retina, but without the spectacle it will make your vision blur. Okay, and then the last layer, the next is retina part, which I say the screen. Okay, last part, retina we got at retina we got an optic nerve. Optic nerve having a million cell, so the cell will transmit it to the brain. So the brain will visualize our vision how it should be. Okay, all right.
So look at the eyes, it's actually very small, but it's very complicated, right? Okay, so questions to Miss Shah right now. So can you share with us some of the examples of the damages that can lead to vision loss? Because we all know that vision blindness is very scary. So can you share a little bit of this?
So thank you, MC. So as Dini explained just now, we need to have a healthy structure of the eye to be able to see clearly. So she actually go layer by layer. So one of the conditions that can cause blurriness will be abnormal media. Media is our cornea, our tears, our anterior segment, our lens, and our vitreous. So you can actually get an ulcer on the cornea, you can get a cataract on the lens, or you can get some bleeding in the vitreous, which is all supposed to be transparent to enable us to see clearly. So another condition is maybe the conduction. The signals from the retina cannot be transmitted properly through the nerves to go to the brain. So then it can actually cause this kind of abnormal visual field, as you can see in the diagram. And also sometimes when we have retinal disorders, we can also get problems with the nerves not being able to see clearly. So as we can see here, this is a cherry red spot from central retinal artery occlusion, and also a central retinal vein occlusion where there's a lot of bleeding. So both of these can also cause blurriness or a loss in vision. So, and next we will go on causes and statistics of blindness and vision loss in Malaysia. Actually, if we look at the National Eye Survey 2 and 3, we also have similar findings, which is the most 58% of vision loss is caused by cataract, which is opacity or a whitish area within your lens, which is supposed to be transparent. So, and followed by diabetes, a diabetic retinopathy, some bleeding and leakages in the eye, and followed by glaucoma and other conditions. So all three conditions actually fall under silent but vision threatening. So maybe I pass the floor back to the MC.
So as we can see that actually there are top 3 of the diseases that we actually call silent disease, because we don't actually know that the symptoms before we actually know that the disease. So questions to Dr. Tan, is this disease very common to the patients, or can you share a little bit more about these top 3 diseases?
Particularly in Malaysia or Southeast Asia or Asia, still cataract, diabetic retinopathy, and also glaucoma is one of the 3 commonest causes for blindness. But however, cataract is so-called reversible blindness. Once you perform the cataract surgery, the vision can be restored. But however, some retinal conditions, like for example, age-related macular degeneration, diabetic retinopathy, and also glaucoma, those are the causes for irreversible blindness. Now, in Malaysia per se, diabetic retinopathy is very, very common. As you all know that our diabetic mellitus rate in Malaysia is very, very high. Also in glaucoma, as we progress into an aging population in Malaysia, and age-related macular degeneration also part and parcel of aging problem. So you will actually see more and more age-related macular degeneration and glaucoma now in our society.
Right. Yes, we can see that the increasing of this eye disease among Malaysian. So questions to Miss Dini as well. So you as an optometrist in the outlets, right? So how often do you see your clients or your customer to actually only know that they had this eye disease when they visit you?
To be honest, at outlet, usually they come just to make a spectacle, right? So they don't know that they have any problem with the eye. But then after we do this, we check for comprehensive checking. We noticed that because at our outlet we got the ADOPS, is a machine to detect the back of the eye, our nerve. So I found that a few not very common people that have diabetic retinopathy, but then got a few that they unnoticed about that. Okay, so for cataract, so far for elderly they have, but then I would say they so scared to do a surgery, but we advise already lah.
So actually we can see that early detection is very important because sometimes when they visit the outlets, they wanted to do a simple eye check, for example, or just they want to upgrade their eyewear. But after that, only they're able to see that actually they need to focus on some of the diseases that might have been. So question to Ms. Chia as well. So can you share a little bit of case study of this kind of the eye diseases?
Yeah, sure. We actually have prepared 6 to 7 cases of example of diseases that is common and silent and at the same time vision threatening. So the first one we have is ADED is advanced diabetic eye disease, the A typo. So this is diabetes. We can see bleeding, leakages. We also can see some scarring. So this is actually a more severe and serious form of diabetes going to the eye caused by poor control. So we can see that this patient is 59 years old. So the diagnosis from our AI, artificial intelligence retinal imaging camera is proliferative diabetic retinopathy. So and we can see that actually the risk is the duration, the longer the higher the risk. If you have any renal disease, if you're overweight, obese, poor glucose control, if you have lipid problem, pregnancy, blood pressure, hypertension, and smoking. So we can also see that Malaysia is actually the most overweight nation in 2010. Actually, we are still the most overweight nation in ASEAN at the moment. And we also are the most diabetic nation in ASEAN. So this is also in 2010, and at the moment we are still champion for that. Yeah. So and also if we can see here. Okay, there's a part of the slide that is not here, but doesn't matter, I can explain. So basically the arrow has a few numbers. It actually shows us that diabetes is very prevalent, diabetic retinopathy is very prevalent, especially even if it's at point of diagnosis, it's also very prevalent, and after a few years it's actually DR is in 50 to 60% of population already. So diabetic population, I mean. So and this is a new research or new study, a new article in the newspaper. At the moment, in year 2019, 1 in 5 Malaysian, 20% of Malaysian is diabetic. So yeah. So maybe I pass the floor back to the MC.
All right, then questions to Dr. Dan as well. So sometimes they will receive some of the referral from the eye clinic checkout, for example. Then what will you do for the patient?
When we receive referral from either from optical shop or some screening eye center, besides looking at the report from the AI generated report, we must perform a detailed eye examination. The detailed eye examination consists from checking the vision, checking the anterior segment from the front up to the back, and we need to perform some relevant investigation as well. You see, the AI screening is just serving as a screening tool, but we have further, more detailed machines that we can use to utilize it and then diagnose it and include that into our management as well, such as the nerve fiber layer scans, such as the OCT macula, to look further into whether the macula have any thinning or any swelling due to diabetic retinopathy, macular degeneration, or maybe later on we'll talk about epiretinal membrane as well. Yeah.
So there are lots of training or checkups after refer to the specialist, right?
Yes, you're right. Yeah.
Okay, so Ms. Chiang, can you share with
How
us
about
the second?
Dini? Dini, do you see DR very common in your practice?
Recently, I have visited with a 60 years old, 30 years old woman. So she come just to change the spectacle, but got a history of diabetic, family history as diabetic.
Yeah.
So I asked her if she have any systemic problem, but she said no. And the last eye checkup is like 3 years ago. Systemic checkup is 1 year ago. So after we settle do the examination, I noticed that she have a sign for diabetic retinopathy, but she don't have any symptom like blurry vision or maybe got a spot. No. Okay. So for this case, I advise her to go for ophthalmology, eye specialist, so that it can further lah. My highlight is that if you don't notice anything, it doesn't mean you don't have any problem. Okay, so if you got a diabetic family history, you should increase. Check your eye, your systemic oftenly lah.
That is very very important because usually we do regular body check, but unfortunately I don't think people have this practice that to visit eye checkup every half a year once or once a year, right? So we also wanted to encourage everyone to at least once in a year to do the eye checkup. At least you will know that even though you don't have any symptom, but you might having this in one day. So regular checkup is very important. So Lisa, can you share the second case study for us as well?
So the second case study is on epiretinal membrane. So it's actually a layer of membrane growing over your macula, your sharpest point of vision. So this is actually seen in one of our roadshows as well. And in this patient, the one on the right, she actually has a macular hole as well. So we can actually see the cross section. You have a hyper-reflective, a whitish layer on the surface of the retina. So we can actually see it. It's also here. We can also see the whitish layer on the surface, and we can see the macular contour is a bit out. And so this patient has an epiretinal membrane in the left eye. We can see the diagnosis from the AI as well, from the artificial intelligence. So, and this is actually very common, although not widely promoted or not widely educated to the public, but this is actually prevalence is 34%. It means for population more than 60 years old, every 3 patients, there's 1 patient who has it. So it's actually very common. Yeah. So I pass the floor back to the MC.
So, top questions to Dr. Tan as well. So, if you receive patients that have this ERM, so usually what we will do for them?
If you look at the photo just now, right, so the epiretinal membrane basically is the puckering of the retina. Our retina is just like a film. For example, you mentioned it's like a camera, right? Everything must be smooth and in order, compact in layer, before it can generate a sharp image and then send the impulse to the brain. So when the layer is not smooth and compact, have a lot of folds, so the image is not going to be sharp. But diagnosing is one thing, to management is another thing. So it will involve. So basically, why we have epiretinal membrane? The eye somehow having some inflammation inside the eye, and following the inflammation, it generates a layer, a fibrotic layer, like a small layer of scar, and then when it contract, and then makes it have the specific appearance. So most of the time, this situation is dealt with the vitreoretinal surgeon. The vitreoretinal surgeon needs to perform a surgery and then to peel off the membrane. But it is considered quite a major surgery. So we diagnose it, we talk to patient. If let's say the vision is severely affected, and then patient complains that it disturbs their daily activity or daily living, cannot function as well as in the normal activities, then we will counsel them for surgery. If let's say their visions are still okay, they're still good, not bothering them, actually we can leave it alone.
So that's why it's very important for early screening because you will know that what to do after that.
Actually, we also saw a case yesterday, right,
Yeah.
Dini?
Yesterday we got one case during the APAC, meaning the advanced eye screening for the roadshow. We got a patient with a 55 to 60 years
Correct,
old.
yeah.
Okay, she came with no complaint, just want to check up the eye.
Mhm.
Okay, we also test either she have a blurry of vision. So far complaint no, but after the fundus examination, they noticed that got pucker.
Correct,
Pucker.
yeah.
And then we try to like do a visual testing and then close monocularly to see either you having a distortion or not,
Yeah.
black spot or not.
Yeah.
So far don't have any complaint, but then we do the MSLR type, which is a grade one. Okay, so she noticed only that she noticed that having a distortion.
Correct. So if let's say a little bit of distortion, if the vision is still okay, I mean, most importantly, the patient is well aware of the situation. And then when it can get worse, you just inform the patient if your visual acuity is getting more poor, and then the central scotoma or the distortion become more. But you have to teach the patient to check on one eye at one time. It is good that you give the AMSLR grid chart to the patient to check the eye maybe once in 2 weeks. That will be good. And then make sure she has a regular ophthalmology follow-up, because we can perform some scan to determine the severity and the progression of the ERM, the epiretinal membrane. Let's say it's become more and more severe, and then we can counsel the surgery for them.
Thank you, Dr. Tan. So we are talking about retina as well. So I know that there is one disease called retinal detachment. So maybe Ms. Chia, can you share with us on
So
this as
our
well?
third case is a retinal detachment on the right eye. So this is detected in one of our outlets in Gurney Plaza, Penang. So this is a Caucasian, is a Australian. He noticed blur vision and he came for an eye test. So when we checked, it was very blur. So we didn't do the refraction, the power check. We actually put him through the adult, and the adult detected this posterior pole retinal detachment on the right eye. So patient is 67 years old and just recently undergone cataract surgery. So risk for retinal detachment is myopia, very long eyeball length, post-cataract surgery, yet laser, lattice degeneration which can happen in maybe in myopic or highly myopic eye, retinal tears, ocular trauma, retinal detachment in the other eye, family history of retinal detachment, and genetic disorder like Marfan syndrome, Sticker syndrome that can cause high myopia, and other conditions. So these are some of the risk factors that can actually lead to retinal detachment. So I pass the floor back to
Okay,
the
Dim.
MC.
Right, thank you. Before that, I wanted to ask Dr. Tan as well. So, can I know that what are the causes for this retinal detachment, and also what are the golden rules when we come into treatment?
So the retinal detachment usually begins with a small retinal break or retinal tear. The retinal break or retinal tear can be predisposed by the risk factors that I mentioned like just now, or can be due to surgery or due to trauma. But most of the time in our society, even myopia is one of the commonest causes. So if you think that way, the myopia causes elongation of the eyeball, or elongation of the eyeball causes myopia, and then following the elongation of the eyeball, the retina gets stretched and become thin. At the very peripheral area of the retina, there are very weak areas. Be it some vitreous degeneration, it causes some traction. Over time, it creates some breaks and holes. So these breaks and holes, when inside the retina, the eyeball will contain vitreous. Vitreous, 90% of the vitreous consists of water. So water go in through this small hole and then separate the retina into layer and cause detachment. So when the patient complains of floaters, so we don't treat it as ordinary floaters. We don't tell them, yeah, you have floaters, then that's it. It's very common. When they're coming to see us, the eye doctor, with a complaint of floaters, we must rule out retinal break and retinal detachment. We need to do a complete eye check to look and then do a what we call Keong 360, a 3 mirror to look at the periphery of the retina, to look for any small breaks or holes. Although from literature, even small holes sometimes will not lead to retinal detachment. Most of the time, the holes can become atrophic holes and then they just leave it that way. However, about 30% of the retinal holes can lead it to retinal detachment. And as we know, retinal detachment can cause blindness. So when, as a eye care provider, as an ophthalmologist, when we see retinal holes, generally we will just do a barricade laser. We just shoot the laser around the holes, make sure it's a patch, and then when it stick down to the underlying structure, it will not progress into a retinal detachment.
I recently have a friend. So one day he wake up, he just realized that one of his eyes blurred. So he went to the eye doctor. So the eye doctor say it's been he estimated that it's been 2 weeks since his retinal detachment, and he just lost the vision of one eye. So is there like a time frame that one should seek the treatment, or what to look out for, like like a lot of floaters, like curtains,
So
and within 24 or 48 hours.
Well, if you see floaters, if you see a lot of floaters, you're all non-ordinary floaters. Typically, like a lot of dots, 20 to 30 black dots flashing. You should see a doctor. If you have a nearby eye doctor, you can see immediately, or maybe the next day, or at least within the week. Because maybe it's just a retinal break. Those floaters, so flashes are just the releasing of the pigments from the retina. But when you start seeing shadows or curtains from the top or from the bottle coming up to the center, that is retinal detachment. You need to seek immediately, the next day, or within 24 hours, whenever the service provider is available. Because it's retinal detachment. If you let the retinal detachment progress, pass to the center and involve the macula, and then your visual recovery is become very, very poor. So when you see shadows, curtain from either side, seek eye doctor immediately. Yeah.
Or else the vision loss will be permanent and irreversible.
It will be permanent. We can do retina surgery to patch it back, but you must understand that retina is part of the nerve. It's very, very, very complicated and delicate. Even though I patch it down, I do surgery and patch it down, restoration of the anatomical restoration does not equals to functional restoration.
Meaning the vision is not going to be very clear as before.
Yes, you have some restoration of the vision, but maybe it's not 100%. Go down to 40%, 50%, depends.
Yes, so that's why that we must very, very alert on our eye condition. So as long as you see something wrong, right? So immediately go for an eye checkup or seek for an eye doctor for a deep thorough checking. So moving on to the next question. We know that glaucoma is also one of the silent thief of sight. So maybe Ms. Chia can share a little bit more on
Yeah,
glaucoma.
so the next case is also from our adult, our AI retinal imaging. So we can see that there is glaucomatous eye in this picture. So if we actually look at the diagnosis on the left eye, there's an enlarged cup to this ratio. And if we actually compare, there is a slight difference on the color of the cup. It's a bit paler on the left. Yeah. So the normal optic disc color should be salmon or pink colored for your information. So this patient is a 53-year-old female patient. So we can see that the cup disc ratio is on the high side. It's more than our normal 0.4, 0.5. It's about 0.65 on both eyes. And we can see that there's a detection of enlarged cup to disc ratio on the left eye. and also the additional retinal nerve fiber layer analysis that this adult can give us tells us that there is nerve fiber layer defect on the left eye as well. So you can see the red highlight in there. So yeah, so that is our current case, which is an area that Dr. Tan specializes in.
Yes, before we move to Dr. Tan, right, also wanted to check with Miss Dini. So, do you, in your experience, do you see that this is very common, glaucoma is very common in among the Malaysian family?
Okay. So to be honest, glaucoma is very rare disease before, but now we see it's increased in the risk already. Okay. So a few, I will say 30% of the patient that came here got a quite high pressure. Okay, but then when we check, because glaucoma is complicated disease, we don't just check the eye pressure, we need to check the cup disc ratio also. So as I mentioned with Miss Chia just now, the cup ratio is 0.6, quite high, quite big. Okay, but then glaucoma patient, we cannot just like detect one time. So when you come here, check first time, got a high pressure or normal pressure, but cup disc bigger, doesn't mean you have a glaucoma yet, but you suspect it as a glaucoma. So we often suggest either 6 months, you can check back with the ophthalmologist, go for eye specialist to check either to confirm either you're having a glaucoma or not. Okay, because glaucoma is a progressive disease. Doesn't mean now you don't have, another day you have, maybe.
Okay, so now question to our glaucoma specialist, Dr. Tan. So in your professions, right? So how often do you see your customers, and also what are the biggest risk factor for glaucoma?
I mentioned before the glaucoma is an aging disease. So as you age, you will develop glaucoma. Then somehow I see a lot of glaucoma being referred by ophthalmologists or other ophthalmologists or even optical center. The risk factor of developing glaucoma, elderly, when you have refractive errors such as myopia, even hypermetropia, you have risk of developing glaucoma as well, either a open angle or closed angle. You have chronic headache, it's not related to the brain, it's because of the eye, high pressure. Strong family history, when you have family history of glaucoma, high likely you have glaucoma also, it's running in the family. And other factors such as diabetes, hypertension, hypercholesterolemia, also a risk factor of developing glaucoma. So I would say that glaucoma is relatively very common in our society. And those individuals who have the risk factors I mentioned, you should have a thorough eye check by a ophthalmologist, maybe at the age of about 35 to 40. So as we all know that glaucoma, when in Malaysia, our screening and awareness are still yet to be improved. Because most of the time when the patient comes to see us as a glaucoma specialist, they are already in moderate to severe glaucoma, in which, as you all know, that the glaucoma, once the glaucoma damage the nerve, it is irreversible blindness. The vision will not be improved. So if you come to see me with a visual function of still about 90%, I can say maintain the 90% for you. But you come to see me when your visual function is only 10%, 90% already damaged by glaucoma, I can only protect or maintain the 10%. That's why early detection, early screening is very, very important.
Like a few days ago on Wednesday here, so we also screened and came across a patient with retinitis pigmentosa and glaucoma. So he's on drops, and then he's on regular follow-up with eye doctor.
Good.
But he's already tunnel vision because his RP is very advanced.
Complicated RP, retinitis pigmentosa and glaucoma, or can coexist together. They are correlated to each other, and generally their prognosis are not too good.
So one more question about glaucoma, right?
Yeah.
So for glaucoma patients, how do you actually manage them?
So one of the modifying factors in glaucoma glaucoma is the intraocular pressure. So we need to bring down the pressure to prevent further damage of the optic nerve. So the normal pressure is about, in a normal individual, should be less than 21. So anything more than 21 is deemed abnormal. So we need to bring down to a safe level. We can set our target intraocular pressure based on the degree of the glaucoma. Generally, in the guideline, now we advocate laser SLT as the first line, and then following by eye drops. And if let's say with the eye drop and the SLT, the pressure is not under control, there's still progression of the disease, it means the patient requires lower pressure, then it will be surgery. And then the surgery also, we have a lot of surgery on our hand right now. We have the minimally invasive glaucoma surgery, or the more traditional, conventional glaucoma surgery, such as trabeculectomy and also glaucoma drainage device. Yeah.
Thank you, Dr. Tan. So moving on to the next case study, Lisha, can you share a little bit more on this AMRD?
So this is something Dr. Tan mentioned just now, age-related macular degeneration. So we can see that in this picture, in the center, there's some like yellowish, whitish spots at our sharpest point of vision, and it's not so clear. Our sharpest point of vision should be a reddish tint with like a dot in the center, but in this picture we can see it's not so sharp. So, and with some yellowish spots. So, and we can see that in this left eye, there's an age-related macular degeneration, early to intermediate, and this is also from our AI retinal camera. It's available in 100 of our outlets. And we can see that there's a very good function here. There's a yellow highlight of where the drusen is formed. So we can actually see where it's affected, and it's quite extensive around the macular region. And yeah, and this is the diagnosis on the left eye. So there's early to intermediate age-related macular degeneration. So as my understanding goes, this is more commonly found in the West compared in the Asian country. Is it true, Dr. Tan?
Yeah, yes. In the Western countries are very, very common. But in Malaysia also.
Increasingly common, isn't it?
Yeah, because the aging population. In fact, age-related macular degeneration and glaucoma, they go hand in hand in the top rank of the irreversible blindness.
Aging.
Yeah. So you look at the government hospital also, a lot of patients lining up for injection. So one of the treatment for age-related macular degeneration is intravitreal injection to the eye, using a very specific drugs method, and then it is very, very expensive. And then you require multiple injections, series of injections. Then only the disease will be under control. Yeah.
But for this, we know that if we don't catch it in time, it can cause vision loss because it's right in the center of the sight. It can cause central scotoma, a black spot right in the middle, and
right.
Cannot recognize faces,
Correct.
Cannot read, cannot drive. So it's actually quite detrimental if we don't catch it in time.
Exactly. So as an eye doctor, we need to monitor the disease. So most of the time, the patient comes to see us, we detect some drusen, but the macula is still normal, it's still dry. Right now, we don't treat them, we just monitor them. If they have risk factors of smoking, we tell them to they stop smoking, take some the vitamin like Vitalux, and increase usage. The consumption of green leaf vegetables, that will help. Then we monitor them, look at their retina, look at the scans to make sure they don't develop the wet AIND. Once you have developed into wet AIND, means that the inflammation starts set in and then fluid building up following the inflammation. That's the time your structure, your macular structure is being distorted. And that's the time you're having visual disturbance, the central scotoma. So we have to initiate treatment as early because once you have prolonged inflammation, the structure will be permanently damaged, permanently scarred. Following inflammation, the solution of the inflammation will be scarred. So if you leave it, the inflammation for too long, then scarring will happen. Then your vision, even though with treatment, the fluid subsided, the inflammation control, but vision function will not return.
So for this, really need to have an early screening as well to
Correct.
better to cure this disease. So moving on to next, I also understand that there is a pathological myopia, also seen very common in Malaysia, right? So can you share a little bit on the case study?
Yeah, it's increasingly common because nowadays there's a lot of people with myopia more than our parents and grandparents era. So we have statistics. By 2050, they estimated that 10% of the world population will be highly myopic, more than -6 diopters. So this is a pathologic myopia case. We can see that there's a lot of degenerative changes within the eye. So we can also see this is a 63-year-old lady with pathological myopia changes in both eyes. And we can see that there's a lot of tessellation. The orange stripes is like stretch mark behind the eye because the eyeball is very elongated. And also moderate to severe pathological changes in the eye. This is the diagnosis. And for pathologic myopia, we can get things like diffuse chororetinal atrophy, patchy chororetinal atrophy, lacquer cracks, choroidal neovascularization, and also macular atrophy. So these are some of the pictures. So, and these are what I mentioned just now, the tessellation, the chororetinal atrophy, the macular problem, the lacquer cracks, and choroidal neovascularizations. So yeah, so I pass the floor back to the MC.
All right, question to Miss Dini. So when you do the eye check for the customer, right? How do you determine that which are the customer that should visit a doctor or whether they just upgrade their eyewear? So how do you determine?
Alright, so for the upgrade the eyewear or just meet a doctor, this is divided into a few things lah. Okay, so for the upgrade eyewear, if the power is more than it's not just a power lah. If the power increase like 75 or 50, 25 to 50 is normal. Okay, so 75 and above, you really need to change the new glasses already. Other than that, if the power is not increased, you need to make sure that your coating of the lens is still okay or not. Apart of that, if you have a symptom like Miss Dr. Tan just now mentioned that got floaters or maybe glaring issue, and then if the power don't have power but got a blurry of vision, maybe have something wrong with the nerve at the back of the eye or in the middle part of the eye. So if you go to focus point, usually they will do a full eye checkup. Full eye checkup meaning that they also check in the middle of the eye and also the back of the eye. So we can detect you're having it's not detect lah. We can like screen either you're having a problem with that part or not lah. So if got part if they mention that you're having a problem with that part, you can directly go to the doctor. If that's not a serious issue, maybe you can delay a bit. But then we very advise you to just directly go to the doctor.
So it's very important that actually customer can or all the audience can actually visit focus point group because they do have these machines or these equipments to help them to do at least the first layer screening before everything before go to the eye doctor, right? Okay, so questions to Dr. Tan as well. So is this myopia something that's curable?
If you look at the trend of myopia development in Malaysia right now, so we are not far behind from places like China, Hong Kong, and Singapore. You don't see much of pathological myopia in Western countries where the education system is a bit different. When you have an education system that more emphasize on the academic achievement, so you have a lot of indoor activities, artificial lights, then you have more myopia. Besides the parents all both being myopia, you have genetic, and then you also have the environment changes as well. So what we, as a doctor, that we need to start myopia prevention or control from the beginning when the patient comes to see us at the age of 4 or 5 years old. So I think the community, like Focus Point, is doing a good job in screening in the community, screening in schools. So make sure the visual detect those who are targeted group or the two at-risk group, and then send to automatic optical shops or to a eye doctor to detect early myopia. Because by the age of about 5 to 6, that boy or girl or the child should have no power at all. Should be no power. But when they have power, then usually it's abnormal. So then we as a eye doctor, we need to prevent the individual or the child to go into high myopia. We don't want it to progress so fast. For example, if every year if progress increase by 1 diopter difference, that is fast progression. So we have to do something to reduce the rate of progression. To prevent it to become high myopia, prevent into the pathological myopia. Because pathological myopia, we have risk of developing early cataract. Besides being the very thick spectacles, not comfortable in sports and a lot of activities, early cataract, glaucoma, retinal break, retinal detachment, and eventually lead to blindness, right? So we need to prevent that. So if you ask me, what's your question again?
Is there any cure,
Cure. So
or treatment?
yes, there's recently we have a very good treatment protocol to reduce the progression. It won't be like when you have myopia, when reverse the myopia become no power at all, no. But we need to prevent it become pathological myopia. So eye drops, we have eye drops, myopia eye drops to reduce the progression. And of course, very important, it's a combination of treatment with myopia control glasses. By namely few company we have is like Hoya, Zeiss, and also Essilor. Yeah, Essilor. Right. So early detection, wear glasses, start treatment, reduce the progression. Hopefully, they will do well later.
So this is why we also have our kids eye test area over here. We also wanted to increase the awareness of parents, because do bring your children over here to do an eye check, because in case that your children have any myopia, we can actually early detect and also can advise you the further steps that you can do to avoid to become periodic myopia. So the next question is, I know that actually cataract is very common, super common in the community. So maybe Ms. Chia, please share a little bit on cataract cases.
So cataract is also a very common silent thief of sight. So we have a case here. It's from one of our Roadshow IOI City Mall. So this patient is actually eczema patient. She uses steroid creams. So because she's been on steroid cream for more than 20 years, so she developed this cataract and she's on follow-up with hospital clank. She's queuing for her surgical removal. So steroid cream is also usage of steroids is very common. We use it in eczema, in psoriasis skin diseases. We use it in allergy, in asthma, and in some inflammation, and after some surgery. So the usage is very broad and it's very common nowadays. So steroid can cause many things. Can cause weight gain, can cause thinning of skin, osteoporosis, bone problem, retardation of growth, cataracts, glaucoma, swellings, emotional disturbances, obesity, raised blood pressure, heart problems, increased body hair, diabetes, and stomach ulcers, and many more, many side effects. So if we are using steroids on the long term, it's important for us to see the eye doctor as well, because it will actually cause cataract and glaucoma secondary to the steroid usage. So I pass the floor back to the MC.
All right. Questions to Ms. Dini as well. Do you see the cases where this kind of steroid-induced cataracts in outlets, and how often or how common is that?
For steroid, in our outlet, it's not that high, but then we see a lot of senile cataract, meaning the aging, the cataract because of the aging process. So for steroid, quite low for us, but maybe in the eye clinic or eye specialist, they got a higher rate of that steroid-induced cataract.
Okay, Dr. Tan, can you share a little bit the cases like this and also how we actually to manage this kind of diseases?
Recently, I have a case in my clinic a few months back, a 21 years old girl. So he has a lot of facial eczema. So she's been using steroid cream, self-prescribed, self-buying over the counter, applying to the face for a few years. Then after that, she developed blurring of vision and come to see us. Both eye having cataract. Long duration on steroid consumption or application will develop ocular problem such as cataract and glaucoma. If compared to local application, especially to the face and around the eye, it is have more effect than systemic consumption. Systemic consumption, if you take it orally, will take longer, but local application will the duration is quite short. You will see the side effect. So told the patient that you have cataract, you are unable to work with that vision. It's only about 660 vision. She's working as a cashier, so you cannot look at the small the figures and things like that. Yeah. So I perform both eye cataract operation for her and implant the lens. After that, her vision is fine. Right. So at the moment now in our Malaysian society also, buying over the counters with steroid, either steroid cream or the oral steroid, is still happening. So you have to be very careful.
Yeah, this is very, very important because usually people will think that only like senior will get cataracts, but actually youngster might get as well if you are using steroid creams as well. So it might affect your vision too. So
I'm actually curious, Dr. Tan. The steroids that they use, after how long is considered like a long-term use, like 2 months, 2 weeks, is there a guideline?
Usually they're used for years.
Yeah. So it's like I see certain eye clinics, you get other departments sending patients to the eye clinic to
Correct.
review their IOP,
Correct.
to review their lens, and after a use for how long they have to start going to the eye clinic to monitor for this.
Usually the oral steroid, for example, kids with nephrotic syndrome, like for example, some renal condition, so they're on oral steroid for long duration. Usually about 3-4 years, they start to have eye complaint. But when we usually see them every 6 months. We don't do cataract surgery immediately once we detect cataract. We have to look at the visual acuity as well. If let's say the visual acuity is still manageable with glasses, so we will tell them, no, you have cataract, but not too bad, we'll monitor you. And when vision is significantly affected, then we do cataract surgery, right? But generally, I think the facial application one is faster. Maybe about 2 years, you start to have symptoms. And the worst thing is that you do not know what percentage, the strength of the steroid you apply to this face. Because some the steroids are low strength, some with a higher strength. And the particular person just buy over the counter, and then it actually proven to it actually is a high strength steroid, so the effect can be faster.
So do you agree that if you are using steroid, it is advisable to see an eye doctor at the same time when you use the steroids? Do you agree with that?
When you're using the steroid, make sure it's been prescribed by
A lot of them buy over the counter.
Exactly. Usually we see them, it's a dermatological patient, means that they have skin problem. Seeing the skin doctor said, I see the skin doctor also give me the same medicine, so I might as well buy over the counter. So this is not right. So you need to use steroid with prescription and under supervision.
Understand.
this is very, very important for any medicines of steroid, right? Must please seek for a doctor prescription before you're using that, because it might lead to more serious issue. Okay, so today we actually covered a lot of conditions that commonly see in Malaysia. So one last thing, can I have each of the speakers to share one advice to the public that, yeah, especially to Dr. Tan.
Like you mentioned earlier, uh, you do eye check, you do blood tests and body checkup every year. So same goes to eye. Um, when you have a certain risk factor, you are advisable to do your eye check every year. If you don't have risk factor, you can do it every 2 years. But once you reach about age about 35 and above, about 40 and above, you are advisable to do every year because that's the time your eye problems will start to emerge. And then if you're able to detect earlier, and then you have to initiate treatment earlier, then after that you can prevent, you can be able to maintain your vision pretty well after that, right?
Yes.
Totally agree with what Dr. Tan said just now. I also want to quote what Dini mentioned, because Dini say if you can see clearly doesn't mean that your eye is okay. So she mentioned that just now, which is very true. So I think if you are a child, if it's your daughter or son, maybe annual checkup would be important to be on the lookout of cataract, myopia and myopia progression. Like if you're 20 to 40, you can do maybe once in 2 years because you're not especially at risk of anything. But if you are above 40, like what Dr. Tan said just now, the risk is higher for glaucoma, and above 60, risk is higher for cataract, then annual checkup would be good. Just a screening with an optometrist. If there's anything, they will refer to the eye doctor. Yeah.
You look at focus point, you look at all the machines over here. Those are good machines, expensive machines, and able to yield good result. For example, you have the fundus camera over there, then you can detect almost 80% of the eye problem, including the retina and the glaucoma side, right? So I think Focus Point has done a very good job in doing screening, roadshow, and education. So hopefully this will raise more awareness to the public, and then the importance of taking care of their eyes.
Okay, as for both Dr. Tan and Ms. Chia mentioned already, because annual eye checkup is important. For me, I will say how early you need to check your eye, especially for kids, because the prevalence for kids now is increasing already. So if parents got either one or both wearing glasses, your children having higher potential to have a myopia. So as early as you can check your eye, because the progression of myopia, we will align with your growth. Okay, so for kids, if your starting point of the myopia is like 200, maybe at 5 years old. Okay, so the progression getting higher till the 80 years old, before it's getting stable, meaning that the prevalence of high myopia is getting higher at younger age already. Okay.
And in terms of myopia, I also agree with Dini. What happens is at the moment the prevalence is increasing, amount of near work is also increasing, like what Dr. Tan said just now. We don't have enough outdoor activity. We don't get enough sunlight exposure, and eye check is very important, especially when the kid starts going to school, because 80% of what you learn is through your eyes. So we do need and send our kids for eye check, especially when they start going to school. If you notice there's something abnormal, like abnormal head tilt or head turn or squinting, or abnormal position of the eye, and the child is very young, non-verbal, or don't understand instruction, then you need to send to an eye clinic for the doctor to put drops. But if the child is like school going, 5, 6 years old, 7 years old, can read ABC, then you can send to any optometrist in an optical shop. We are able to help you check and detect whether there's anything abnormal with the eye. Because if they are not able to see clearly, it affects their learning and also affects their quality of life. Yeah.
All right, thank you so much. Thank you to Dr. Tan, Miss Dini, and Miss Chia for sharing your expertise with us for all the conditions that we might be facing nowadays. So I think we all can agree that our vision is very, very precious. So it's very important that to take care of our vision and take care of our eyes by do early prevention, which is early screening. So here we are today, we brought to you by Focus Point 360 APEC Roadshow. We do have 4 levels of different eye screening for you. So please do ask your families or friends, please come around, bring them to our roadshow today. Or we are here until 14th of September. So if you are yet to do an eye screening this year, please remember come to our roadshow today to do a free eye screening today. So once again, thank you so much to the speakers. Thank you.
Thank you.